Good afternoon everyone. My topic is first trimester scan. First trimester is defined as the viability can be confirmed up to the 13 weeks 6 days of gestation according to SHOC guidelines. It is a critical period when 80% of the miscarriages occurs and also ectopic pregnancy occurs, which is the leading cause of the maternal death. The transvaginal sonography is the imaging modality of the choice in the evaluation of the first trimester pregnancy. It provides the highest resolution images. The main objectives of ultrasound examination in the first trimester: confirmation of pregnancy, intrauterine location of the gestational sac, confirmation of the viability, detection of signs of the early pregnancy failure, single pregnancy or multiple pregnancy. In case of multiple pregnancy, to define the chorionicity, assessment of the gestational age, assessment of the normal embryo and gestational sac before 10 weeks, assessment of the basic anatomy after 11 weeks. The first sonographic evidence of pregnancy is the gestational sac. It is also called as chorionic cavity. We can up to 4 weeks there is no evidence of pregnancy on scan. After 4 weeks you can see first is the gestational sac. It is round or oval shape, eccentric to the central echogenic area, that is called the intradecidual sac sign. It is surrounded by the two echogenic rings. The outer ring is the decidia parietalis, inner ring is the decidia capsularis. Pitfalls of the true gestational sac. Pseudogestational sac, it is seen in 10 to 20% of the ectopic pregnancies. There is a fluid or blood collection in the endometrial cavity present in the central of the endometrium. It is elongated with acute angles, avascular structure. We can measure the gestational sac with mean sac diameter. We can take in three planes of in two views with three planes. In longitudinal we can take the two measurements. In transverse view we can take the one measurement. The total of the three measurements by divided by the 3 is the mean sac diameter. Mean sac diameter in millimeters plus 30 equal to gestational days. Gestational age in days. When mean sac diameter is 16 to 24 mm without visualization of the embryo is suspicious of viable pregnancy. When mean sac diameter more than 25 mm without visualization of the embryo is called the fetal embryonic damage. Then coming to the next structure, yolk sac. This is the first structure you can see in the gestational sac. This is a small ring-like structure with echogenic borders. We can see at around 5 weeks 5 days of gestation. The yolk sac is the maximum size reaches up to 6 mm. It provides the nutrients to the embryonic development. The number of yolk sac represent to the number of amniotic cavities. It becomes obliterated at 14 to 16 weeks of gestation. The next structure is the thin echogenic ring-like structure appears. The embryo will develop in the amniotic cavity. The egg sac and amniotic cavity are connected by the vitelline duct. Because of appearance of the two fluid collection sacs in the one gestational sac, looks like a bleb sign. Then embryo. The embryo you can see at 6 weeks 5 days of gestation on transvaginal ultrasound. The embryo is first seen as a focal thickening on the top of the yolk sac. It looks like a diamond engagement ring appearance. Cardiac activity may be seen here in the at 6 weeks as a flickering movement. At 6 weeks of gestation, the embryo appears as a tube-like structure. You can see it appears as a grain of rice appearance. At 8 weeks, because of appearance of the curvature, it looks as a gummy bear. At 10 weeks, the clear visualization of the anatomical structures we can see. Then the embryo measured with a CRL, that means crone rump length. It is the most accurate method used for the estimation of the gestational age in early pregnancy. It measures in the mid-sagittal view the longest dimensions of the embryo from the top of the head to the end of the fetal spine. We should exclude the extremities and embryo should not be flexed. The head should be in neutral position. It measures between 6 to 13 weeks of gestational age. If the CRL is more than 7 mm with no cardiac activity, is diagnostic of failed pregnancy. Then fetal heart rate. We can measure the fetal heart rate using the M mode. It is detectable at 6 weeks of gestation and initially it is 90 to 110 beats per minute. After that once reaches up to 140 to 170. Then after 10 weeks it gradually slow down and maintain at 110 to 160 beats per minute. Here in this picture you can see the cardiac flicker in the embryo. Then first trimester abnormalities. First one is the early pregnancy failure. When the chromosomal length of when the CRL length is more than 7 mm without cardiac activity, we call as fetal embryonic demise. When mean sac diameter is more than 25 mm without embryo is called the embryonic failure. Then absence of embryo with fetal heart rate at 2 or more weeks after ultrasound showed gestational sac without yolk sac. Absence of embryo with fetal heartbeat at 11 days or more after ultrasound that showed a gestational sac with an yolk sac is called the. These 4 definitions are called the embryonic failure. In the first ultrasonographic picture, you can see small gestational sac. After 2 weeks follow-up scan, the mean sac diameter was increased to 25 mm, but there is no fetal pole and yolk sac. These are the findings suggestive of early pregnancy loss. Then in second picture, there is presence of the intrauterine pregnancy with fetal pole embryo also we can see with CRL of 1.1 centimeter with corresponding to 7 weeks 2 days. But on the second picture, you can see there is no fetal heart rate. It is the intrauterine embryonic demise. Then coming to the subchorionic hemorrhage. Subchorionic hemorrhage is the most common finding in the first trimester. It occurs in 18 to 22% of the intrauterine pregnancies in the patient complaining of bleeding PV. On transvaginal ultrasound, it appears as a crescent-shaped heterogeneous avascular collection between the gestational sac and decidua basalis. When hematoma is occupying more than 2/3 of the chorionic circumference, there is increased risk of pregnancy loss. Here you can see in this picture, first picture you can see the gestational sac with embryo around the chorionic cavity, 180 degrees of the hematoma collection you can see. Next one. Ectopic pregnancy. This is the most common complication of the first trimester pregnancy in which embryo implants outside the uterine cavity. The incidence of the ectopic pregnancy in India is 0.91%. In that, tubal pregnancy is the most common one where the fertilized egg implants within the fallopian tube. In the first picture, the uterine cavity is empty. On the second picture, the arrow marks showing the measurement showing the right ovary. Adjacent to the right ovary, there is the presence of the gestational sac with yolk sac and fetal pole also. On third picture, you can see the fetal heart rate also. This is the compatible with the right adnexal ectopic pregnancy. Then coming to the cervical ectopic pregnancy, this is a very rare one. In the ultrasound, we can diagnose ultrasonographically. The uterine cavity is empty and the arrow mark showed a gestational sac below the internal loss, and the absence of sliding sign. There is increased blood flow towards the gestational sac and seen on color Doppler also, diagnostic of cervical ectopic pregnancy. Then coming to the ovarian ectopic pregnancy, in this also uterine cavity is empty and sliding sign is absent, and you can see the corpus luteal cyst could be seen separate from the gestational sac in the ovary. Then coming to the corneal pregnancy, this is also very rarest one. In pregnancy occurring in the rudimentary horn of the bicornuate uterus, the horn does not communicate with the main uterine cavity. When visualization of the single interstitial portion and on ultrasound, you can see the single interstitial portion of the tube in the main uterine cavity. The gestational sac is seen and is separate from the uterus. The gestational sac or products are surrounded by the myometrium. The differential diagnosis for the corneal pregnancy are the broad ligament fibroid or ovarian mass with the pregnancy. Then intraoperatively you can see the normal uterus and the rudimentary horn, and cut section you can see the fetus and embryo. Heterotopic pregnancy, this is the incidence of heterotopic pregnancy is 1 in 8,000. Heterotopic pregnancy is more common following the ART procedure. Heterotopic pregnancy means the presence of the two gestational sac but in different places, ectopic pregnancy and intrauterine pregnancy. In this picture, intrauterine gestational sac with fetal pole you can see, and another one is the cervical pregnancy, that is there also gestational sac and fetal pole you can see. Then role of ultrasound in multiple gestation in chorionicity. In case of dichorionic diamniotic twins, there is 2 gestational sacs are there and 2 amniotic sacs are there. Separating the both fetuses are separated by the thick membrane, intertwin membrane. The intertwin membrane thickness is more than 2 mm in case of DCDA twins. In monochorionic diamniotic twins, there is single chorionic cavity is there and 2 yolk sacs, that means 2 amniotic cavities and 2 fetuses. So these are monochorionic twins are identical twins always. There is thin intertwin membrane that is less than 2 mm. Then in DC-D8 twin peak sign, you can see the thick triangular, the star, you can see the star on the plus corion that abutting the inter-twin membrane, forming twin peak sign or lambda sign. In case of DC-D8 twin, that is diagnostic. In MC-D8 twins, there is no, this membrane is attached in the T-shaped configuration. In momo twins, monochorionic monoamniotic twins, there is no separating membrane in between these two fetuses. The only single chorionic cavity and single amniotic cavity you can see. Most of the complications occurs in the momo twins. The conjoined twins, these features also like momo twins, but they are conjoined together at different places. Coming to the second part of the first trimester scan, that is the NT scan. Before going into the details, we can assign the gestational age. In the first step, you should know the first day of the last menstrual period. From that, you can calculate the EDD, that is 280 days from the LMP. And on scan, you can measure the CRL measurement between 6 to 13 weeks of gestational age. It is most accurate method to assign the EDD. You can assign the EDD by CRL when if the discrepancy between LMP EDD and scan EDD is more than 5 days up to 9 weeks. If the discrepancy is more than 7 days up to 13 weeks 6 days of gestation. And ART cases, you can calculate the EDD based on the day of transfer. Then coming to the beatal biometry also. During NT scan also you should take the measurements, all the measurements of head circumference, BPD, abdominal circumference, femur length. Because in case of, if you diagnose severe asymmetrical FGR, it may be associated with triploidy. If you find out short FL during biometry, it could be skeletal dysplasia. Then nuchal translucency. Nuchal translucency is measurement of a collection of the fluid behind the back, the back of the neck. It can be seen in mid-sagittal view. Actually the technical aspects of the NT scan measurements are the fetus head should occupy the 3/4 of the image, and the head should be in neutral position, should not be flexed, should not be extended, and you should wait for few seconds to differentiate the fetal amnion or fetal skin to measure the NT scan. The calipers should be placed between the inner layers of the nuchal translucency. That it can be measured between 11 to 13 weeks or 13 weeks 6 days of gestational age, when the CRL is between 45 to 84 mm. The lower limit of the nuchal translucency is 1.2 at CRL 45 mm. The upper limit is 2.7 at CRL 84 mm. It provides the risk assessment for chromosomal abnormalities and also some structural abnormalities. If you do NT scan alone, you can detect the anomalies only 70 to 80%. If you combine with the double marker, you can detect improve to 85 to 90%. When combined with NIPT, non-invasive prenatal testing, 90 to 99% improvement of detection rate for anomalies. Then these physiological structures that looks pathological. The one is the Raman-Keflan, typically visible at 8 and 10 weeks of gestational age. It looks like a holoprosencephaly, but it is a normal physiological finding at 8 to 10 weeks. It appears as a round fluid collection, fluid-filled anechoic structure in the posterior part of the fetal head. The next structure is the midgut herniation, seen at around 6 to 8 weeks of gestation. This normal finding up to the 12 to 13 weeks of gestation age. To accommodate the rapid growth of the midgut, it herniates outside the abdominal cavity through the umbilical opening. Then there are two levels of screening of anatomical structures according to modified ISHPA guidelines. One is the basic structural survey, second one is the best practice for comprehensive detailed examination. The right one is the basic anatomical survey, the left one is the advanced anatomical survey. In head and brain, on transventricular view, you can see the calcification of the cranium, contour and shape of the cranium. If the failure of calcification, it leads to the acrania and followed by due to chemical reaction of the brain tissue, exencephaly followed by anencephaly, and two brain halves separated by the interhemispheric parts. If it is not separated, it forms the alobar holoprosencephaly. Choroid plexus is almost filling the lateral ventricles in the posterior 2/3. It looks like a butterfly sign. And in Coming to the advanced examination, in transthalamic view, you can see the thalami, brainstem, cerebral peduncle with aqueduct of the sylvius, intracranial transparency, that is fourth ventricle, and cisterna magna. You can measure the BPD and head circumference in that plane, transthalamic plane. Coming to the neck and face. On the neck, you can confirm on basic survey, confirm whether nuchal transparency thickness less than 95th centile. On advanced examination, bilateral orbits also you should be you have to examine, and pre-axillary triangle, nasal bone is present or absent, and intracranial translucency also. Then thorax and abdomen. On transaxial view of the chest, you can see the 4-chamber view in the first picture. In that, in basic survey, you can do heart inside the chest with regular rhythm. In the same view, you can measure the cardiac axis also. And shape of the thoracic wall, lung field, diaphragmatic continuity, situs, 2 inflows, LVOT, 3 vessel tracheal view, tricuspid regurgitation, and ductus venosus flow. Then on abdomen, you can see the stomach, basic anatomical survey, stomach visible or not, intact abdominal wall, bladder visible and not dilated. In the first picture, you can see the stomach and inferior vena cava. You can measure the abdominal circumference here. And the next second picture is the umbilical cord insertion into the abdominal cavity. And the third picture, you can see the axial view of the pelvis, showing the thighs and bladder. And in fourth picture, you can see the 2 umbilical arteries bordering the bladder. In the fourth coronal view, you can see the both kidneys. Next. And extent is visualization of the 4 limbs, each with 3 segments. And advanced, you can see the free movements also. Spine. The longitudinal of the spine, you can see regular shape and continuity of the spine. Coming to the major fetal malformation, these are always detectable, that means 100% detectable anomalies during NT scan. Those are anencephaly, limb defects, megacystis, gastrochisis, omphalocele, body stalk anomaly, a lobar holoprosencephaly. You should not be missed during NT scan. These neural tube defects, congenital heart diseases, and cleft lip, cleft palate, these are the lethal, potentially detectable anomalies in the first trimester. If you find some markers during NT scan, these are the more, but these congenital anomalies are burden in India. The birth prevalence rate of congenital anomalies are 18 to 23 per 1000 live births. In that, neural tube defects 9.4 per 1000 live births, congenital heart diseases 9 per 1000 live births, cleft lip, cleft palate are 1 per 700 births. Then coming to the markers to detect the CNS disorders. During CNS open spina bifida. Before going into the markers, we should know the pathophysiology of the open spina bifida. Due to leakage of the CSF, the cisterna magna and fourth ventricle obliterated, so that due to negative pressure, the mesencephalon is displaced posteriorly against the occipital bone, so that the fourth ventricle means intracranial translucency, that will be obliterated, so that obviously decreased intracranial translucency. The space between intracranial translucency means the space between the 2 echogenic lines of the posterior border of the brainstem anteriorly and choroid plexus of the fourth ventricle posteriorly. And it is now the lower limit of the IT value is 1.5 mm at a CRLF 45 mm to 2.5 mm at 84 mm. Then coming to the next marker, reduced frontomaxillary facial angle. This angle between a line, draw a line between along the upper surface of the palate and a line that traverses the upper corner of the anterior aspect of the maxilla extending to the external surface of the forehead. The normal degree is 84 at CRL 45, 76 degrees at CRL of 84. Because of the flattening of the frontal bones in case of open spina bifida, the 10 degrees will be less in open spina bifida, this angle. Next. The third one is the reduced, actually to detect the open spina bifida, there are more than 10 markers are there, but here I am explaining only 6 only. The third one is the reduced aqueduct to occipital bone distance. Here in the first picture you can see the fourth ventricle measurement. The arrow marks you can take. That box like structure is the aqueduct of the sylvius. From the posterior border of the aqueduct sylvius to anterior border of the occipital bone, the normal value is 1.7 mm at CRL 45 mm to 3.7 mm at CRL of 84 mm. The next one is the maxilla-occipital line. You can draw a straight line from the along the superior border of the maxilla until it reaches the occiput in the mid-sagittal plane of the fetal face. After draw the line, if the junction between the midbrain and the brainstem is above the maxilla-occipital line, that is normal actually. In case of open spina bifida, the angle will be below the maxilla-occipital line. Increased brainstem occipital bone distance in case of open spina bifida. The A representative is represent as a brainstem, the B is the fourth ventricle, C is the cisterna magna and below occipital bone. Because obliteration of the cisterna magna and fourth ventricle, the brainstem diameter will be increased, so that obviously increased brainstem occipital bone distance will be increased. The normal is the 0.8 at 11 weeks, 0.7 at 14 weeks, abnormal more than 1. In crash cell, because of displacement and deformation of the mesencephalon against the occipital bone in the axial ultrasound, this is called the crash cell. The wall is the occiput and the car is the mesencephalon. Coming to the next CNS malformation is the Dandy-Walker malformation. The signs are opposite to the spina bifida. Here you can see because of cystic dilatation of the fourth ventricle, the intracranial translucency diameter will be increased and decreased brainstem occipital bone distance. Ventriculomegaly, this is the second trimester anomaly. You can detect in the first trimester also if you find out these two diameters. The choroid plexus too small to reach the roof of the ventricle and when reduced ratios between the choroid plexus and ventricular dimensions. Then coming to the markers to detect the cardiac defects. There is no specific markers to detect the cardiac defects. Though when you find out the aneuploidy markers during NT scan, you also do the advanced exam, early fetal echo to rule out the cardiac defects. Most of the 30% of the severe congenital heart diseases are associated with the neonatal morbidity and mortality. If you detect early in the first trimester, you can terminate the patient may opt for termination. The detection rate will be improved when the heart examination. When you do the heart examination in the 4-chamber view along with the 4-chamber view and 3-vessel tracheal view and color Doppler also. The aneuploidy markers are when there is increased mitral translucency and presence of tricuspid regurgitation, reverse flow in ductus venosus, you should always examine the cardiac anomalies. Then the signs to detect the cleft palate are the maxillary gap, palatino-maxillary diameter, superimposed lines and pre-maxillary triangles. The maxillary gap, come next. Here in the first picture you can see the normal fetus, there is no maxillary bone. Here there is no maxillary gap, this is a maxilla, there is no gap. Here you can see the small maxillary gap, here you can see the partial gap in this. These are the suggestive of the cleft palate and this is absence of the maxilla. So that is the complete maxillary gap. Most of the cleft palate are associated with the additional abnormalities also. Then coming to the palatino-maxillary diameter, that is measured, it is a shortest distance between the ossified areas of the upper posterior palatine process and the anterior maxilla. It is reduced reduced palatino-maxillary diameter is indicative of isolated cleft lip and cleft palate. Then superimposed line chain. Here in the first picture you can see the arrow mark, vomer bone and maxillary bone, they are both are superimposed, that is normal. In the second picture you can see the vomer bone is absent, that is only palate is there, only secondary palate is there. Next, if you do the detailed anatomical examination. If you diagnose the specific anomaly, if it is that is lethal, go for invasive testing, because don't do the non-invasive test, because to rule out the you can detect the presence of single gene disorders in our family also. And if you detect the lethal anomalies, you can terminate the pregnancy and always send for autopsy. If you suspect any specific anomaly, if you have any doubt, you can refer to the senior fetal medicine experts. If the abnormality of undetermined significance is there, follow up at 16 weeks. These are some undetectable anomalies in the first trimester. These are microcephaly, agencies of the corpus callosum, ventriculomegaly, ovarian cyst, fetal tumors, SEEP and duodenal atresia. Conclusion: rule out ectopic pregnancy, which are responsible for 6% of the maternal deaths. Accurate gestational age is determined by the measuring CRL in early trimester. Nuchal transparency is being evaluated as an additional tool for early detection of the fetal aneuploidy and other fetal abnormalities. The NT scan, along with the detailed anatomical assessment and systematic use of the anatomical markers, it is expected that more anomalies will be detected at 11 to 13 weeks, 6 days of gestation. Abnormal suspected cases can refer to highly skilled operators in specialized centers. Advantage of the early detection anomalies is that it allows the more time for additional investigations and counseling, and the patient may opt for termination of the pregnancy at a stage which may be less traumatic. The first trimester scan is not a replacement for the second trimester scan, because the anomalies could be evolving in the further development also. Thank you.